Hi friends, sometimes we face this situation in Phaco 3 as I am trying to aspirate the epinucleus. I am not able to do so. What to do now? We will see in this case. So it's a routine case, grade 2 cataract. I always instill 5% betadine to wash the conjunctival sac. Outside the OR in shifting room, we put epidine for a contact time of 2 to 3 minutes. Here again we put betadine to wash out on the meibomian secretions or any dust particle. So it helps in clear the cornea and the sac area. I always put visco over the cornea to have a clear view. Now we will be making a posterior limbal incision 2.8 mm in width. Try to make a tunnel length of at least 1.5 mm to avoid any iris prolapse and to maintain the chamber intraoperatively. It's a 3 planar incision, as you can see. The entry was done. Pushing air bubble inside the eye. Now we'll stain the cornea with Tryphan blue. I use Tryphan blue in all my cases to stain the cornea. Now using phenocaine to dilate the pupil. It also helps for patient comfort during surgery. Pushing visco to remove the air bubble. Now it's time to do the capsular access. I usually use 26 gauge needle on a 2 ml syringe to do the capsular access. Going anti-clockwise, our aim is to have our axis of at least 4.5 to 5 mm. In softer cataracts and hard cataract, both cases you should have a bigger axis. In grade 2 cataracts, even our axis of 4 mm can work. Generally, we think that our axis of 4.5 mm is sufficient in soft cataract. It's not so. Softer cataracts sometimes are more difficult. If you have a bigger axis, it's easy to prolapse the nucleus and do phaco, because sometimes it's difficult to get a crack in these soft cataracts. Here we have grade 2 cataract, making a side port 4 clock hours away from the main port. Now time to do some AC lavage, doing hydrodissection, compressing the nucleus in between to relieve any pressure buildup behind the nucleus. Multi-quadrant hydrodissection is done. Pushing visco. Now I will use a dialer to rotate the nucleus. Check the hydrodissection status. As you can see, I'm able to rotate the nucleus, but it's little bit sticked. So we'll again do some hydrodissection. Nucleus should be easily rotable. Otherwise, during phaco, it will put stress on the zonules. So you should not hesitate to repeat the hydrodissection. Visco is injected again. Now we will check the nuclear rotation with the help of the dialer. As you can see, the nucleus is freely movable now. Pushing some visco. Now it's time to start the phaco. Entering into the eye with phaco 1, we have planned stop and chop in this case. Removing some epinucleus. Now making a trench 1.5 width of the phaco tip and trying to go at least 80 to 90% of the depth of the nucleus. Here, while applying the phaco power, you should take care that it should be sufficient and there should be no pushing mechanism while making the trench. You can rotate the nucleus also to complete the trench, dividing into two. Both the handpiece and the dialer are in the depth of the trench. Got the break. Now shift it to Phaco 2. Each hemisphere of the nucleus will be prolapsed towards the center and will be emulsified. Got hold of the D piece. You can see the horizontal chop. Here my settings are vacuum is 400, power is 60 and flow rate is 45. Phaco emulsification is done into the central part of the AC, the safest zone. The other hemisphere is brought towards the front. Again horizontal chop and the piece is emulsified and aspirated. Shifting to Phaco 3 with a vacuum of 200, power of 25 and flow rate of 30. A part of epinucleus is aspirated. Still we have a lot of cortex and epinucleus in the back. As I am trying to aspirate the epinucleus, you can see it's going back. Again trying at some other quadrant, but again not very successful. Partly came, but still we have a large chunk of epinucleus and cortex in the back. So I decided to remove the phaco and to do the hydro again, pushing the visco inside the eye. Now I will do some hydrodissection again, pushing some fluid between the capsule and the epinucleus. As you can see, it's bulging upside. Here you have to take care of few things. First, the cannula should be positioned between the capsule and the epinucleus to avoid any push of the saline through the zonules. Second, the push should be very slow. You should not push very hard. There is a chance of hydration of the vitreous. Third, you should take care that sudden movement of the patient eye can cause damage to the posterior capsule. So these three things you should be taken care. Now pushing some visco inside the eye. Now we will be moving towards the cortical and epinuclear wash with the help of the coaxial. We will aspirate the remaining epinucleus and cortex. Now it will be very easy. Here you can also use Phaco 3 with the help of the Phaco probe, but I directly straight away went for aspiration as the epinucleus and cortex was free and easily removable after doing the hydrodissection. As you can see, the adhesions are broken and we can easily aspirate the cortex and epinucleus. Here the vacuum is 400 and the flow rate is 35. For safety, my probe is in the center. We are aspirating with full vacuum in the center of the eye. Only few cortical tags are remaining. You should never apply the full vacuum at the periphery. Only once you come to the center you can apply it. In periphery you should have a low vacuum. You aspirate, hold and bring it to the center to apply the full vacuum. Now it's time to put the lens. Visco is injected, HPMC 2%. Here we are using Care Group magnificent lens and advanced monofocal lens. The lens is pushed inside the eye. One haptic is in the back. Other haptic will be pushed inside the bag. Now it's time to do the AC wash. Removal of visco in front of the lens and behind the lens is very important step. You should give some time to this. The visco should be washed from all the angles, and if you are not able to go behind the lens, you can tap the lens. That also helps in removal of the visco behind the lens. An increase of pressure can be avoided next day. I use Alcon BSS in all my cases. The iris prolapse, after I remove the coaxial, you can reposit it slowly with the strokes. Doing some AC lavage with the BSS. Now hydrating the wounds. The main wound is hydrated. You should take care that DMD should not happen. Side port is hydrated. Here you can put a little more pressure and the case is completed. Thanks for watching.